I think we are live, Dr. Erkan, so I'm just waiting for the confirmation. Yeah, we are live. Well, we are back again. Today is November 5th, 2021, Bariatric Friday by American Surgery Center and CHRIAS. My name is Kemal Erkan. I'm the chairman of the Surgery Center, American Surgery Center, and I have Dr. Isaias Irgau with me, our president, and we are here to discuss Bariatric Friday topics on another Friday. So I'm going to ask Dr. Erkan to introduce himself, and then we'll start there.
Hello, everyone. Thank you, Kemal. My name is Dr. Irgau. I'm the president of CHRIAS, or Christiana Institute of Advanced Surgery. My specialty is bariatric surgery or weight loss surgery, and I have been performing weight loss surgery now for 20 years. And along with my associates at CHRIAS, we are actually by far the most experienced group when it comes to weight loss surgery or bariatric surgery in our area. Hello again, and thank you for coming to watch us on Bariatric Friday.
Thank you, Dr. Erkan. So I just want to mention a couple of our program updates and other providers. So again, this is mainly the bariatric surgery journey, which we call it as Bariatric Friday. Our providers, other than Dr. Ergau, we have Dr. Gail Wynn, Dr. Michael Peters, Dr. Rose Singh, and Dr. George Ibrahim. They're on the bariatric team. And then we have Dr. Sachin Vaid, who's part of our colorectal team. We do have 3 dietitians with Fran, Amy, and Beth, and we actually have one more joining us this month. So hopefully there will be a total of 4. And what we are trying to do in these events is to break these issues of the bariatric surgery journey into smaller topics, and then discuss these issues with our audience and with our patients who are already in the program. So, Dr. Ergau, what I would like to do is bring this image up. Now, well, you didn't see this one yet. This is the first time, like this not like you didn't see this specific image, like you know where this comes from, but you didn't see this specific one. Can you tell me what we are seeing?
Sure. So what we have here is we have a graph, which on one side, it shows us weight. On another side, it shows us progression of time. So we look at the weight around just after February 2017, and the weight was around 296, 297, right? And then we go further in time now. Now we are 4 years later, right, around May of 2021, and the weight is somewhere else. The weight is way higher now. It's about 50 pounds higher, right? About 346 now. So that is actually a typical progression of this disease, Kemal. That what you showed us is a very, very common thing. And patients very often wake up, you know, one day because they have a scale and they measure themselves and they see. So a weight that they have not seen creeping up on them, actually, it is creeping up. So it tells us morbid obesity actually doesn't stay there. It's a chronic progressive disease, which means that as the years pass, the weight gets worse. There is more and more weight accumulating. It doesn't hold there. And I am absolutely certain, as you know, Kemal, this particular person that is represented by the data we have on that graph is probably somebody who's trying very hard to lose weight in their own way, whether it's by watching what they eat or by trying to stay active. But unfortunately, those methods are not effective with dealing with this disease. And the result is 2-3 years later, the weight is much higher than where it was when they first looked at it.
So, Dr. Ergau, that actually, this image, like I knew that we have our presentation for today and the topic, but this is from today's case conference. So as we do these case conferences on a daily basis, you know, sometimes I do take advantage of the daily case conferences in a way that I can actually get some data for our presentations. And this is the point when we are trying to tell people on a regular basis what it is that we do, why what we do is extremely important, is because every day we don't take an action, it gets worse. So this is a patient who started our program 3.5 years ago and did not finish. So every time I see this, it actually breaks my heart, because for our nursing team, sometimes I have to make references to show them actual data. And then this is from our EMR, this is from our power chart. And I just took this picture and I said, I'm going to actually make this part of our presentation for today, because it is related to what we discussed. So this patient, as you mentioned, starts with 296. First time they didn't finish it, and now they come back. They're a new patient now. They're at 342 pounds. So if we were able to handle this patient's surgery in end of 2017, this patient, in my opinion, there's a 4-year loss that they have from their really young age, and they could have been healthier. And this is not an exception. Every time we have patients who are on the bariatric side, BMI 35 over, 40 over, these are patients who are going to actually, 97% of the time, they're going to gain weight in time. So we really try so hard to get them in and then make them stay in the program. So that's why we have built the program the way that we did under Dr. Irgau's clinical leadership. So this is from the referrals, from the PCP to the consult with the surgeon, surgical clearance, and the surgery schedule. This process is 3 to 6 months process. So during this time, while we are going through so many different things, but what we would like to talk to you, Dr. Erkan, today is what these patients are seeing as benefits. So here's one patient, and it may not be your specific patient, but this patient's second time going through the surgical process.
Yep.
And they could have done it before, but now someone who started with 321 pounds,
yep,
and now they're down to 239.
Yep.
And we are not just talking about weight, right, Dr. Irgau? So if you can just walk us through with different illnesses that this patient may have, what they go through and what they expect after the surgery.
Absolutely, absolutely. So as you correctly said, it's not just about the weight. Even for the graph that we showed earlier on, where there was a progressive increase in weight, concomitant with that, there will be a progressive worsening of illnesses that are directly associated with morbid obesity. We know that morbid obesity, when we look at it as physicians, when we look at it as healthcare providers, we're not looking at it only as something that is an inconvenience for the patient, and we know that it's an appearance issue, it's an inconvenience issue, and also carrying that weight is such a burden physically, so that even some minor tasks that many people would take for granted as not giving them any difficulty, they are very difficult, whether it's taking care of themselves, tying the shoelaces, or scratching their back, whatever it is harder when the weight goes to that much. But really, our focus as physicians is really that the morbid obesity becomes a source of very serious illnesses, right? Cardiovascular illnesses like high blood pressure, like heart disease, metabolic illnesses like type 2 diabetes or hyperlipidemia, or very serious problems of the respiratory system like sleep apnea, right? So these are very serious illnesses, not just when they are together, but by themselves. Each disease by themselves, each single disease is actually a dangerous disease by itself, let alone when they are grouped in such a way, when very often we see them with a person that has morbid obesity. So what we see, the reason we know these illnesses are actually directly correlated to weight is actually simple. When the weight comes off, those illnesses also either disappear or become much easier to manage. If a patient was taking 2-3 medications for high blood pressure, they are likely to have no medication or much less medication to control it. If a patient had type 2 diabetes and they were on multiple medications to try to stabilize their blood sugar before, after surgery, once they lose weight, they either need no medications any longer, or they will need much less medications to control. So what you're showing us here, Kemal, is that a typical picture of what morbid obesity is. Morbid obesity is a disease where the main problem is not only excessive accumulation of weight expressed in a very high weight when we weigh the patient, but also the presence of those illnesses that you're showing on your slide: type 2 diabetes, high blood pressure, hyperlipidemia, which means high cholesterol, and then sleep apnea. These are real dangerous conditions.
So, Dr. Irgau, this patient did not, like, for example, this patient in this case did not have, obviously, diabetes. Not everyone is going to have. So, but they did have hypertension. Mm-hmm. They did have hyperlipidemia. What's hyperlipidemia again?
Hyperlipidemia essentially is high lipids. It's commonly known high cholesterol.
High cholesterol.
Yeah, exactly.
So, and then sleep apnea, and then these three illnesses they have, and then after this much weight loss, we expect them to not to have most likely hypertension, not to have high cholesterol, and not to have most likely sleep apnea. Now, many people, they may not know, you and I, we use these terms every day. The CPAP. If you don't mind just explaining what CPAP is, because this patient was using CPAP, and why they use the CPAP, and what would happen after this weight loss.
Absolutely. So when a person has sleep apnea, essentially what it means is that they are not able to exchange air during their sleep freely, right? The accumulation of fat in most people who have sleep apnea around the back of their mouth prevents adequate exchange of air, which means that they have periods in which they actually stop breathing, right? And those periods of stopping breathing, the worst sleep apnea is, the longer and the more frequent these are. There are actually studies that we can do, tests that we can do to measure that. Now, why is this a problem? This is a problem, actually, Kemal, because it's dangerous, it's life-threatening, right? When a person is not breathing for a prolonged period of time, some of the carbon dioxide that they are supposed to exhale when they are breathing normally accumulates in their system, right? And that at a certain point gets to a dangerous level, and the brain is alerted to wake the person up. So the person will suddenly wake up and take a big gasp, right? But what if that person does
snoring as well, right? That's when
right, exactly.
So a couple of times, and it was it settled so well, like I understood so well. So I tell people what it is that people are going through. So that's if you can just repeat that, if you don't mind just repeating. So what we are saying is during the sleep, like sometimes when people are taking a nap, I always take a nap at my own family, but my mom and my dad both snore. Depending now, I'm snoring. So the time of that snoring, and there's that part that where it goes up, and then boom, all of a sudden there's a little bit silence, and then that person just wakes up. So yes, that's the time that you are describing, right?
Absolutely, absolutely. So what happens essentially, the snoring really is an indication that there is a narrowing of the passage of air around the back of the mouth because of the tissue that is accumulating there, right? So, but that could go to a level where there is no passage at all at some point, right? And then that person stops breathing, and then that's the pause that you described, right? And then after that, the person is woken up suddenly into taking the breath, and the waking up suddenly happens because there is almost like an alarm system in our brain that instigates us to, hey, breathe. But the question, Kemal, is what if that person has taken some medications or alcohol or other things that suppress that alarm system? Mm-hmm. What happens if they don't wake up, right? Then obviously they may not breathe again, right? That's life-threatening. And then there are other things also that we know. The higher the degree of sleep apnea, the more strain there is on the cardiovascular system. There is strain on the heart, so that a person could actually have a heart issue during their sleep, right? So, and many people actually can have even died in their sleep because of sleep apnea. So in order to fix this, what doctors prescribe is something called a CPAP machine, which is essentially almost like a mask that is placed around the face of the person. and there is a machine that forces air, so it will overcome that narrowing of the air passage in the back of the mouth, forcing air through. So that's how the CPAP machine is there, right? Now, what we're saying is in the vast majority of people, sleep apnea is caused by excessive weight, by morbid obesity. So when our patients have surgery and they lose weight, what we see is that they don't snore and they don't have sleep apnea any longer. So they don't need the CPAP machine any longer. So that's one of the big benefits that we see in our patients. They get out of sleep apnea. So one of the consequences, of course, of sleep apnea is that if it's not treated, is the sleep pattern is also restless. So typically patients who have sleep apnea, they will tell you, I am constantly tired. I feel like taking a nap. I have to take a nap during the day. Why? Well, because the sleep is being disturbed by the sleep apnea as well.
So one of the problems that patients, I'm trying to show, okay, here's the image. I'm trying to get an image of the machine itself. So this is one that may not be the same, but it's pretty complicated and cumbersome for many people. And the reason actually we know this is because during the process of getting the clearance, if patient has sleep apnea, then they need to be treated. And then the CPAP actually is the treatment. And then also for after surgery, we want them to be able to, wake up, number one. So, and if they don't have the CPAP, once they're home, then they're going to be in trouble. So, but not being able to use this after the weight loss is important, right?
Absolutely, yes. Because as you correctly said, Kemal, it's a cumbersome machine. Of course, it takes time to get used to it as well. So nobody would want to sleep with that machine if they can avoid it, obviously. Now, when people have sleep apnea, until they lose weight and the sleep apnea is effectively gone, we definitely make sure that the patients have the use of the machine. In fact, as you correctly said, when we suspect that a person has sleep apnea, as we evaluate them for bariatric surgery, one of the things that we do is we send them for a sleep study. And if the sleep study confirms that there is significant sleep apnea, then we recommend that person gets treatment in the form of an APAP or a CPAP, knowing that once they lose weight, they may not need it any longer. But as they are going through the surgery, it's important for them to do that. It's important that it's treated, first of all, because obviously there is the safety issue, right? You're going to go through anesthesia, you're going to take some medications, and with all that, we want to make sure sleep apnea is not a threat to that person, right? But also importantly, we want them to be fit from a cardiovascular point of view. Their heart, their blood pressure, blood control, and those things may not be optimal if that person is constantly struggling with sleep apnea. So treating sleep apnea in this fashion, as our patients are preparing and going through surgery, is important for us, although we know that ultimately the definitive treatment for sleep apnea is weight loss, which obviously our goal is to do that as well with bariatric surgery.
So, Dr. Irgau, I want to go to our second patient. This patient, excuse me, was at 309 and BMI 51. Patient have seen in their past 348 pounds. That's their heaviest. Now, again, this patient, unlike the other patient, does have diabetes. And then they do take medication for that.
Yep.
And they have hypertension.
Yep.
In this case, they don't have high cholesterol, but then they do have sleep apnea.
Yep.
And then they are using, obviously, CPAP. Now, what this patient is expecting after the surgery, if we can just walk us through.
Absolutely. So with weight loss, as we said earlier on, there is improvement or resolution of the comorbidities. So if we have to take in order, which disease is likely to resolve first and resolve completely, the first one that we see, Kemal, with a high degree of frequency is sleep apnea, right? With adequate weight loss, the vast majority of people who had sleep apnea before surgery, that goes away after bariatric surgery, right? The second one that we see great improvement is type 2 diabetes. With type 2 diabetes, particularly for a person who has been diagnosed with type 2 diabetes less than 5 years before surgery, the chances of them having no diabetes after surgery with adequate weight loss are very high, right? The third one in order is high blood pressure, right? Now, high blood pressure may not resolve completely once it's established, but its control becomes much, much better after bariatric surgery. A common call that comes to our office, even within 2-3 weeks after surgery, Kemal, is a patient who says, oh, I am feeling dizzy as I get up now after surgery, right? The first question we ask them is, are you still taking your blood pressure medication? And their answer is yes. Well, now with the surgery and with the weight loss, their blood pressure is improving, which means that the blood pressure medications that they were taking before are too strong for them, and they are driving their blood pressure too far down. That's why they're feeling dizzy. So the first thing we ask them to do is to hold off from taking their medication and call their primary care doctor or their cardiologist so that adjustments can be made to their medication. So that's what we commonly see. So of those 3 diseases, sleep apnea, high percentage of resolution and a high frequency of resolution. Next to that, type 2 diabetes. Next to that, blood pressure.
So, one of the issues that I see, Dr. Irgau, I think the way that we are approaching, not you and I, we are, but society and the medical society too, the obesity, morbid obesity is kind of left alone by many PCPs. As you know, like I spend about 2 hours of my day on the clinical side, 1 hour with the bariatric, the other hour is with the ACO. And when I see patients with diabetes and with high A1C, with the hypertension, with the sleep problems, I'm not going to make up the number, but 70 to 80% of the time they do have morbid obesity. And then I see that PCP takes care of everything else, but then there's this, I'm not feeling comfortable if the patient is not going to bring this up type of attitude that I see. I think that needs to be, I don't know how and what can be done to improve that, because we are trying so hard with our ACO, and then I think we do much better. But I know that other offices where they don't have the structure that we have, they may not be getting these feedback from the care management team. But I see that obesity is still not being treated properly. Although what we are saying is that obesity actually is the root of the problem, that many of these problems are going to go away. Like, you may have diabetes, even your BMI is 24, right? So you may be in the best, weight, and then you may still have, and then the hypertension, the same, the hyperlipidemia. Yep. Well, actually, hyperlipidemia is interesting. I'm not going to mention the name, but one of my former employees who, they're all younger than me, and when one of them when he get his lab results, he was always bragging about them being younger. So, and his cholesterol was 260. And, someone who's, 20 years younger than me, I'm like, well, see, like the age doesn't make much. And then, he was a healthy guy overall, but he didn't know that he has high cholesterol. Mm-hmm. So this is what I'm trying to say, is that these illnesses, you can, independently, you can have those, but when you have morbid obesity, chances are you are going to develop these problems in time, and then those are the ones that we are reporting back to our national surgical quality team. So, because this is not just for us, but this is everywhere in this country and then around the world, these problems are happening. But I still would like to see the approach being much more effective and efficient in a way that so they are actually able to talk to patients directly even if the patient is not bringing this up. So because this is like you can just take care of the problems and then not go to the root of the problem, because they're going to keep coming back. So I just still don't really understand why that would be happening.
Absolutely. I mean, that is really a very important point, Kemal. We are making progress clearly in that many of the primary care doctors now are freely referring patients for bariatric surgery and also recommending bariatric surgery, but a lot needs to be done. And really, when you look at our fight against obesity in our society, Kemal, the number one obstacle is the stigma of obesity itself, right? I mean, that's really the major barrier we have, because society has not been able to see beyond the fact that nobody chooses to be morbidly obese, right? I mean, and yet people ascribe morbid obesity as the fault of the person, and more significantly, throw the treatment of morbid obesity on the shoulder of that person, fully knowing that that person could be trying all their life and they're not going to be able to get out of there unless they have help, right? So here we are saying there is help, there is effective, safe treatment, and yet what percentage of patients who have morbid obesity are getting bariatric surgery now in 2021? Come on, 1%. Isn't that terrible? I mean, means there are 99% of people out there who could benefit from the treatment that we offer, and yet we're not reaching them. We're not reaching them because of the stigma of obesity that is so prevalent and entrenched in our society, so much so that it is also prevalent within healthcare itself, where discussions about weight become a difficult discussion, even for healthcare providers. We have to get out from there.
Here's what's so interesting. And again, I don't want to, I want to stay focused on the topic, but here's what's really important there. If you see a patient, if you see someone, and if you know that their A1C is 12, and then if you don't mind just explaining what A1C is, so you do better when you're explaining.
Absolutely. So A1C is a blood test result. It's a laboratory test which shows us the blood sugar control over a long period of time. So when we do a blood sugar test, for instance, on the spot, Kemal, we see what's happening that minute, that day, right? But when we look at hemoglobin A1C, we are looking at what has been happening to the blood sugar control over many, many months. So we can see how, bad diabetes is in that person, or how poorly controlled diabetes is. So as you correctly said, a level of 12 is just too high. It just means that there is absolutely no control of diabetes in that person.
The reason I'm asking this is because the reason I'm bringing this up, because I have a hidden agenda. So the A1C 12 is really high because the normal A1C level is hemoglobin A1C level is 5.7. For each point over the normal weight, someone is 10% more at the risk for heart attack. So let's say 6 would be the normal. So then 6, this person, 12 is 60% more chance of getting a heart attack is 60% more.
Absolutely.
Now, let me ask you this. So when you see that patient, not you, but medical professional, PCP, sees that patient, they don't say that, I'm not feeling comfortable bringing this up. If you have A1C 12, you have the information there, but then no one says, oh, well, I was going to tell you something, but I'm not going to because I didn't feel that it's a sensitive issue. Well, then there's a patient with BMI 45, and you're not having the obesity discussion. That's not acceptable. Because if you don't see this as the main origin of the main problem, and if you have someone with A1C 12 versus someone with BMI 45, it's the same thing. In fact, the A1C 12, good endocrinologists can bring that down very quickly, but the 45 BMI is going to take several months to get it under the normal limits. So unless medical society approaches this in a way that this is just like anything else. So you have BMI X, so you are this, you have this. So then we have to take care of what needs to be done. Because when the doctor or the provider doesn't feel comfortable, how can we expect patients to be comfortable? This is nothing to be uncomfortable about. This is a chronic illness. So, and I would like to see that change in my lifetime, hopefully.
Absolutely,
so
absolutely.
Dr. I have one other patient. I don't want to cut. I don't know if you want to.
No, go ahead.
One other patient that this patient does, like I picked, we discussed some of these patients in the past, but because they are already safe. So this patient was at 260. Now, 1 month after the surgery, they're down to 228. So that's 32 pounds in 1 month. So now patient's 30-day BMI was 37.9. It was from 41.96. Now, this patient had, prior to the surgery, from the top 4, they had one of the issues, which is the high cholesterol. However, they didn't have other problems, but however, they have this other problem, which we call that GERD, right? What's GERD? What is this again?
So GERD is heartburn or acid reflux, is commonly known as. Essentially, what it means is that the acid in the stomach, which is really way, way, way stronger than the acid anywhere else in our digestive tract, can sometimes reflux back into the food pipe, and that not only causes symptoms, but it can cause some irritation or even inflammation of the food pipe. So this, again, is something that is very commonly associated with morbid obesity or with obesity, because one of the causes or one of the factors that exacerbate heartburn is increased pressure inside the abdomen. And to have increased pressure inside the abdomen, what you have is increased weight. So patients will very often tell us that their heartburn got worse as they gain weight. So with effective weight loss surgery, very often the heartburn will go away. Now, the issue of heartburn, as you and I have discussed before, is a little bit more complex than the other comorbidities, because sometimes there are certain operations that can make the heartburn even worse. And then there are other operations, also bariatric procedures, that can eliminate it completely. Having said that, in general, with decreased weight, with decreased intra-abdominal pressure, which is the result of weight loss surgery, the expectation is for heartburn to get better as well.
So, Dr. Irgau, the one other thing that I have that I'm just going to bring up. So we focus on 5 main problems, but obviously this is not limited with the 5. So there are so many other issues that patients have. Like one of them is, we didn't discuss, is depression. So many of these people have depression. The other problem is cancer. The other problem is the gallbladder disease. We discussed the fatty liver issue last couple sessions before. Gynecological abnormalities, pulmonary, which we discussed today. So there are so many different parts of this. And I believe that when you look at in the whole picture, the main thing is this is the root of the overall well-being. It's not something that it's some lifestyle or this or that, but it's the main problem. So that's why we have to really take care of this. We have to approach it as this is the solution to the problem that patients are having, illnesses that they're having. And we are hoping that we are able to increase the awareness of these issues. Now, if you would like to add anything that we didn't maybe cover.
No, I mean, I think what you said earlier on, you said, I would like to see this change in my lifetime, Kemal, about the attitude towards morbid obesity and the much more aggressive approach also from all of us in terms of addressing morbid obesity as a really significant problem. Well, it's not just a problem for individuals, it's a problem for a society as a whole. If all society has, such a high degree of morbid obesity, it means we have a sick society, we have a disabled society, right? That is going to be difficult to be taken care of because the multiplication of the illnesses related with society and their impact on healthcare is just going to be unmanageable. So just like the sessions that you and I are doing on Bariatric Friday, we will bring some awareness, we will bring some understanding of this, and I am absolutely certain that we will make progress on this. We just have to push for it.
No, that's definitely. I know that we are doing our part from our organization, but again, changing the perception requires a bigger effort from everyone else. And absolutely. I'm hoping that we can reach out to more people and also help our patients to understand that they are not alone in this process. Yes. So we have qualified people in the team. We have the one of the nicest thing about our, from my point at least, is when I know that we have the most experienced surgeons in the nation. That makes a huge difference overall. And then this is our specialty. This is our main specialty in American Surgery Center. So, Dr. Irgau, thank you so much for joining us. We'll be back next week. Well, we discussed the Thanksgiving and the holiday issues, and I think we're going to go into that a little bit more deeper. So, we'll be back in a week. Thank you so much for being with us, and we'll see you soon.
Thank you.